Hemo. I'm a medical officer working at the Haemophila clinic, and I'm part of the effective Haemophila team that helps to manage the condition of our patients. And today is our first series of webinars. We are going to be handling management of hemophilia and also bleeding manifestations in girls and women. Then tomorrow we are going to have another series, which will be more interesting. Probably I'll talk about it as we conclude. Now, as I start, I want to say that April is our Hemophilia Awareness Month, and we have the World Hemophilia Day that is on the 17th of this month. However, as Kenyatta National Hospital, we'll be having our day on the 16th. And so probably much later, I'll get to speak a bit more if time allows. So allow me to introduce our presenters. And we have Dr. Rebecca Mwakichako, who is a clinical hematologist located in Voi County Referral Hospital. And Dr. Rebecca is the current chair of the training committee of the Medical Advisory Committee of the Kenya Haemophila Association, and she has got a keen interest in training and capacity building of healthcare workers, management, advocacy, and research in the field of hemophilia, particularly in low and middle income settings. And she will be talking about the management of hemophilia. Then we have our principal nursing officer by name Roseanne Anguche, and she is passionate about hemophilia management in our patients, and she's been quite effective also as part of my team at Kenyatta National Hospital. So I want to invite every one of you to feel free to ask any questions through our chat box. And after the presentations, we are going to allow the panelists to share their answers or to probably help us understand more where we could be having more questions. So allow me now to present to you, to invite Dr. Rebecca Mwakichako. Welcome, and thank you. I can see the slide, Dr. Becky, so you can try and make the presentation now.
All right, so apologies for that. We'll just begin. All right, Dr. Gichuma, are we okay?
Yes, we are good to go. You may continue.
All right, excellent. So I'll just go straight to the topic of our discussion. and that is on management of hemophilia. And I appreciate the team from KNH for inviting me to be part of this discussion. So we'll define hemophilia, look at clinical presentations, management options, and we will look at then management of specific bleeds in regards to hemophilia. So when we talk about hemophilia, we are basically saying that it's a bleeding disorder that can be either inherited or acquired. But for the purposes of this discussion, we will limit ourselves to the inherited type. And usually the patients inherit a defective gene, either factor 8 or 9, depending. And it's usually inherited in an X-linked manner because these genes are actually found in the X chromosome. Now, usually once the patients have this defect, they would then present with deficiency or lack of clotting proteins, and therefore the hallmark is bleeding tendencies. And we have different types. The commonest is hemophilia A, where the patient has a defect in factor 8, the factor 8 gene, hemophilia B in factor 9, and C in 11, which is very rare. Now, in normal hemostasis, you know that we have different components, including platelets, the coagulation proteins, and intact endothelium, the anti-coagulation, the natural anticoagulants, as well as a fibrinolytic system. And they work very well to ensure that they maintain a very good balance of bleeding and thrombosis and clotting, so to speak, so that it's a delicate balance. When we have a lot of anticoagulation, then there's hemorrhage, and in the presence of uncontrolled clotting, then there is thrombosis. Now, usually in a normal setting, when a patient or a person encounters injury to the vascular endothelium, the first reaction is that the vessel goes into spasm, and this is just to ensure that the body protects itself from bleeding. And in the process, platelets that are usually just found centrally flowing, not close to this procoagulant subendothelium, now come into contact with the endothelium, they get activated, they aggregate there, forming the primary platelet plug. And once we have then initiated coagulation, then we go down to forming fibrin, which is very important in stabilizing the primary platelet plug, and therefore ensuring that the patient is stable enough to allow healing, remodeling, and finally restoring the function of the vessel. Now, this is just a schema of the coagulation pathway, which we will not discuss in detail, but I'll just bring to your attention that we have an intrinsic pathway, an extrinsic pathway, and a common pathway. But the most important thing is to remember that we want to ultimately form fibrin, which is then going to be the meshwork that is going to lay down our platelets, stabilize that platelet plug, and in the process, in the presence of factor 13, form a very stable component that can be able then to protect us from bleeding. Now, if you look at the intrinsic pathway, then you are able to see that factor 9 is crucial there, as well as factor 8, which is usually a cofactor. And in the absence of this, then these patients then have hemophilia. Now, this is basically how normal patients would present when there is injury. So we've talked about the platelet plug being formed, stabilizing it with this fibrin molecule, and therefore sealing sort of that injury and allowing the blood and allowing the vessel to heal and restoring function. But when you come to a patient who's got hemophilia, therefore you can see that for as much as they form the primary platelet plug, they're not able to strengthen it. And as a result, these patients will therefore continue bleeding. Now, in terms of the epidemiology, we are talking about over 1 million patients diagnosed with hemophilia, and this is by the World Federation of Hemophilia. And we've got prevalence of about 17 patients per 100,000 males and 3.8 per 100,000 males for hemophilia B, just knowing that A is more common than B. And it is important to understand that it does not have a geographical distribution. So unlike conditions like sickle cell disease, where you'll find them probably around malaria endemic areas, hemophilia can be found everywhere and anywhere. And that is why it's important for healthcare providers to maintain this as a differential diagnosis when you have patients who are presenting with the bleeding tendencies that we are going to talk about. Now, in Africa, for as much as we have these large populations, we have very few patients identified, and there are various reasons to that in terms of including capacity building, not having enough diagnostic equipment or technical know-how, as well as just having other competing interests, including infectious diseases, cancers that are just sort of coming in and taking our priorities, so that we are not really able to focus much on hemophilia. In terms of the genetics, we've said that it is the gene is in the X chromosome, and therefore it is inherited in an X-linked manner. Now, it's important to understand that far as much as we are saying that it is inherited, and therefore a patient should present with a family history, only 70% of your patients will give you a family history of bleeding tendencies in their relatives. And therefore, you have a particular 30% who indeed have hemophilia, but they may not give you this particular history. And this is because it's occurring as a result of spontaneous mutation. And therefore, it's important to remember this, so that if you have a patient presenting with bleeding tendencies in the absence of a family history, and you still need to screen them, because we are saying that 30% can occur in spontaneous mutations. Now, based on the pattern of inheritance, the males will have hemophilia and females will tend to be carriers. But we will talk about this more, and I know even in the second presentation, it will be emphasized that far as much as we know that females will tend to be carriers because they've got two X's, and therefore when one is affected, there's a normal one that function. Females as well can also have hemophilia. Now, this is just a genetic schema, just showing us the different scenarios that can occur for a patient to end up with hemophilia, where you're having the first scenario, you're having a normal father with a carrier mother, and you're able to see that in this situation, there's a 50% chance that the sons that are going to be born by these parents will have hemophilia, and therefore you also find another 50% of if they had females, there's a likelihood that one could be a carrier. And if you go to the second scenario, where you're finding a father with hemophilia, you then find a scenario where males do not manifest the disease, because then they get the Y chromosome from their fathers, but then you have 100% of the daughters now coming in as carriers, which is extremely important even as you go back to do your family tree tracing. And in a scenario where you have a carrier mother and a hemophilic patient or father, then you're actually seeing that there's chances of having a hemophilia patient who's male, but also another chance of having a hemophilia patient who's female. And we also have carrier daughters coming in as well. Now, when we classify, usually normal coagulation, so your normal proteins will be about 50 to 150%. But then anything below 50, then we begin to classify you either as mild, if you have 5 to 40%, moderate, whether you have 1 to 5%, in severe type, where you have less than 1%. And this classification is important because we begin to see the presentations of our patients mimicking the kind of, or the severity, based on the severity that they have, so that you have severe patients having severe kind of presentations, moderate patients having this moderate kind of presentation, and mild patients sometimes being diagnosed even very late because of the mild kind of presentation. But maybe to just mention that far as much as we know that this is how these patients present, there's now knowledge that phenotypic presentations can also vary, so that you might find a patient who has got mild hemophilia presenting as if they have severe type, or severe patients presenting as if they have mild. So far as much as you want to keep these details at the back of your mind, you also want to add on to that phenotypic presentations can vary, and therefore you need to understand the individual way that your patients are presenting. So can women have hemophilia? And the answer really is yes. We have seen a scenario of a female born to hemophilia father and a carrier mother, but far as much as they have a normal X and an abnormal X, and in the cases of carriers, you can have inactivation of the normal X, so that what is actually manifesting is the abnormal X with the defective gene, what is known as skewed lionization, and these patients can therefore present as hemophilia, and really they are hemophilia patients. The other thing to remember is that for as much as you could have a patient who's a carrier, you want to establish their factor levels, because if your patient has a factor level of less than 40%, then they are no longer carriers. Even when they have a normal X, they are now patients. And this is important because we are beginning to find varied ways in which our carrier patients are presenting, and some are actually presenting as if they've got hemophilia as patients. And when you actually look at their factor levels, they are way below the 40% mark, and this will be further emphasized in the second presentation. Now, when you look at the historical discussion of hemophilia, you find that it was there even in the long, or rather in times, the Jewish areas where we knew that these sons were circumcised quite early, and you were told that if you had two sons dying because of excessive bleeding during circumcision, then the third born should not be circumcised. And this was just sort of saying that these patients probably could have had hemophilia. So how do they present? We say that it's based on severity and phenotype, but basically because there's a compromise in the coagulation pathway, your patients, the hallmark of their presentation is just abnormal bleeding tendencies. And as we mentioned, patients who've got severe type will have spontaneous bleeds, and these are patients who tend to bleed into deep joints. So you have joint bleeding, muscle bleeding, internal organs, and these are the patients who you also tend to diagnose quite early in their life. So if they were circumcised early, but also because of issues like early bruising on ambulation, muscle hematomas. So the parents would just tell you, once this child started to crawl, we noticed that there were probably some bruises, or so to speak, in their arms or on their knees. And these are just some of the early ways that these patients would present. For moderate hemophilia, they would have varied presentation in terms of the age in which they present. They tend to have prolonged bleeding, even with minor procedures or minor trauma. And occasionally, you could also have patients with moderate hemophilia presenting with spontaneous bleeding. Now, patients with mild types sometimes can pose a great challenge to healthcare workers, because these patients would come to you and you will probably begin to diagnose them with hemophilia when they have major trauma or major surgery, because they usually might not have this kind of abnormal bleeding, and they may not give you even a history of abnormal bleeding. But then when you go back to screening them, you realize that they have a particular compromise in their coagulation pathway. So you want to be very meticulous when you're dealing with some of these patients. And that's why in certain hospitals, you find that coagulation screen is mandatory for patients who go for surgery. So in terms of diagnosis, we'll just run through this quickly. You want to ensure that you understand the clinical history and also the family history. But we said that you have to also remember there's a 30% of your patients who might not give you a family history. So clinical history, they might tell you that, oh, I noticed that I had this kind of bleeding tendencies. Sometimes I pass blood in my stool. Sometimes when I have this nosebleed, sometimes I have hematuria. And my brother also had a similar kind of presentation. Sometimes it gives it away, especially for people who tell you that, oh, I had prolonged bleeding during circumcision, and even sometimes I lost a brother or a cousin during circumcision. So it's very important to understand the clinical and the family history of these patients. A CBC is still important because you want to make sure that they do not have any issues with their platelets, so that you are probably just going down to a coagulation screen knowing that they have a full hemogram that's normal. Though because of recurrent bleeding, these patients tend to be the kind of patients that you see with iron deficiency anemia. So that's probably one of the other things that you will see in your CBC. Now, for coagulation screen, they tend to have a prolonged PTT, and this is because factor 9 and factor 8 are in the intrinsic pathway. And when you do a mixing study, which is basically taking the patient's plasma that you know is deficient of certain factor and mixing it with normal pooled plasma, when you run the APTT, that prolonged PTT that was there when the patient sample was run is corrected. And therefore, you know that probably there's something in my patient's sample that is lacking that has been replaced from a normal pooled plasma. And that's the essence of a mixing study. And after that, you're able to do a factor assay so that you're able to say, okay, this is hemophilia A, this is hemophilia B. And also going on to do inhibitor screen, especially for patients who had been previously exposed to factor concentrates, and we'll talk about that a bit later. And genetic screen is still important because it's able to help you to understand the kind of mutations that the patients have, because certain mutations are even sort of known to predispose patients to the development of inhibitors once they are exposed to factor concentrates. Now, your principles of management, you want to remember that it is comprehensive and it is provided by a multidisciplinary team. And the essence of it is that you want to make a diagnosis, you want to treat the patient at that particular point, and you want to manage complications. And you need to understand that there's a lot of collaboration, including between the clinical team, the patient and the caregivers. And now there's a whole lot of discussion on shared decision making when it comes to the management of patients with hemophilia. And really, for those who have managed patients with hemophilia, we just don't call them patients. We actually acknowledge that they are actually partners and experts in the management of their disease. And you would realize that some of these patients would even know a lot about the kind of products that they use, what works for them, even more than healthcare workers who have not had experience with these patients with hemophilia. So you want to incorporate them very earlier on as partners in the management of this condition. And this is just a schema just showing you who then comes in as part of the multidisciplinary team right from, and you're seeing that in the center, at the center is really the person with hemophilia, but you're having a medical director who will probably be the medical officer or the pediatrician or the physician who's managing the patient, a nurse coordinator, the team from the musculoskeletal side, psychosocial support, lab, and in the allied specialists, including orthopedic surgeons, neurosurgeons, depending on how your patient is presenting. So you cannot be managing a patient with hemophilia alone. So in terms of the evolution of treatment, patients management has really gone through different stages, and it's usually exciting to look at how this management has developed over years. And earlier on, they would just be given whole blood that, of course, we know didn't help them much. And over time, then it was discovered that FFP and cryo did support these patients with hemophilia, and therefore they were able to even produce the commercially available factor 8 from plasma. But because in the 90s, because of then coming with HIV, patients who had hemophilia were then infected with HIV, hepatitis B and C, because most of the plasma components that they were using were not virally inactivated. And these patients died from complications of AIDS or from hepatocellular carcinoma because of hepatitis B and C. And that then took us to the point where we now had products that were virally inactivated, and this even allowed home prophylaxis. And then towards now, developing even safer products, including recombinant factor 8 and 9, which we now use very well, and even taking it back to the extended half-life products so that you have less infusions for these patients. But then later on, we actually realized that some of our patients began to develop antibodies or alloantibodies against recombinant factor. And because of that, we then went on to the development of non-replacement therapies, including things like emicizumab that we will mention. So this basically just tells you that there has been a sort of just this development of treatment for patients with hemophilia. And even right now, we are embracing gene therapy, and a number of patients have actually gone through that. Now, factor replacement therapy is your mainstay when you're managing these patients, and usually it's to prevent and to treat the bleed, and you want to replace it. You want to replace with the deficient factor that this patient has. So if it is hemophilia A, then you want to give them factor 8. If it is hemophilia B, then you want to give them factor 9. And it can be given on demand, meaning the patient bleeds and you give them factor, or prophylaxis, which is you give repeated doses 2 to 3 times in a week for a patient to prevent bleeding. And this is actually the global recommended standard of care for patients with hemophilia. Now, unfortunately, in our side of the world, because we do not have enough factor, most of our patients are on demand treatment and not prophylaxis, and that comes with complications including arthropathy and disability because of recurrent bleeding in their joints. Now, for appropriate management, you want to know the diagnosis of your patient, you want to know the severity they have, you want to know the inhibitor status, and you want to know what is the other type of product that they have used before. And you also want to know what is in terms of the dosage of your treatment. Do I want to treat it as if it's a severe type, moderate, or mild bleeding? And you also want to ask maybe who was the previous physician managing this patient, because they might have information that would be relevant to you. So quickly, we'll just mention that you can replace factor from plasma products, as we saw from the earlier slide. And the only problem with this is that it's not as safe if you do not have virally inactivated products. But these days, once you have donor testing for hepatitis B, C, and HIV, then safer products are made available. The only problem with FFP is that though it contains all the coagulation factors, it's very difficult to achieve levels higher than 30 international units per deciliter, and therefore it may not really give you the adequate in terms of factor that you want to replace for your patients, and usually a starting dose of 15 to 20 mils per kg is adequate. For cryo, what you want to remember for patients with hemophilia is that it has larger concentration of factor 8 and not 9, and therefore this is better for patients who've got hemophilia A. And a bag would usually contain about 70 to 80 units of factor 8, which can be adequately used, but of course not as better and not as good as the concentrates themselves. Now, for concentrates, is what is recommended. This is what we recommend, and it has very high doses of factor concentrates, and it can either be plasma derived or from recombinant technology. And for patients who have and when you look at factor 8, you would have your dosages running from 250 to about 300 international units, and the half-life tends to be about 12 to 24 hours. And you want to know the half-life of the product you're giving so that you know after how long you want to repeat your infusion, if it is then necessary. Factor 9, again, usually, I need to mention that 1 international unit per kg of factor 8 would usually replace your factor levels by 2%. And this is important when it comes to calculation of replacement factor. For factor 9, you have 1 international unit raising you up to only 1%. And it can be given as a slow infusion, or it can be given as a push, as a slow push or an infusion, especially for continuous infusion for patients who are going in for surgery. And the half-life tends to be a bit longer, anywhere between 18 to 24 hours. But again, you want to look at the product specification so that you know how much factor is actually, what is the half-life of your product. And these are just images of some of the factor concentrates that we have in the market. And currently, patients receive most of their factors on donation here in the country by the World Federation of Haemophilia. So in most of the facilities, usually the patients will receive this factor for free. Now, emicizumab is one of the known replacement therapies that we have for patients with hemophilia, And unlike the factor concentrates that are given IV, this is given as a subcutaneous injection and usually is used for prophylaxis, meaning if a patient came with bleeding, you would not give them emicizumab. And the mechanism of action is quite different, and this is because it's a bispecific antibody that binds to activated factor 9 and therefore activating factor 10 and continuing the coagulation cascade. And initially when it was produced for patients who had inhibitors, but now it can be used for patients regardless of their inhibitor status and even regardless of their severity. And we have a number of patients with hemophilia on emicizumab here in Kenya with very good outcomes. And gene therapy, again, there's a virus that is injected that's able to then go in and support the production of factor that initially was missing in the patient. And still not many patients have access to gene therapy on our side of the world, but there are many other in other centers or other countries that have access to gene therapy. So when it comes to management of specific bleeds, as we wrap up, we want to just mention certain sites that are crucial for you to take note of when you're treating your patients with hemophilia. And one of them is joint bleeding, and usually these are classified as serious bleeds, and this is because patients could end up with disability if it is not well managed. Now, if you look at all your patients who have hemophilia, majority of them would tell you that they have encountered a joint bleed in one time or another in their lifetime. Most of the time, they affect hinge joints, and these are joints that move in one plane. And also, as we said, repeated bleeding can result into permanent destruction of the joint and disability. Usually, these patients would present with have a tingling or a tightness that they are feeling, and usually this is the best time to give factor therapy for these patients before now they progress to having pain, they have this swelling and a progressive loss of range of motion. Now, muscle bleeds and ligaments as well as tendons can also occur, and usually they are triggered by sprain or a blow or overuse. And it is important to understand that this bleeding can occur in compartments, including the retroperitoneal space, the buttocks, the scrotum, and the thighs. And some of these patients could end up with compartment syndrome. Now, you want to note that because we know that compartment syndrome can come with other neurovascular compromise that you want to take care of, but also the fact that bleeding into some of these spaces can lead into shock. And if you do not know that and your patient goes into hemodynamic compromise, and a number of patients have died because of this kind of bleeds. Now, you want to evaluate your hemogram, your HB, you want to evaluate your vitals so that you see whether your patient is not in shock, and also you want to evaluate the function of your neurovascular structures. Now, these are just some of the images of patients who have muscle bleeds, patients who've got bleeding that is occurring in joints as well. And you can see that there's one particular patient who had intervention because of compartment syndrome. So as we said, these are patients you manage immediately at the aura stage, and you want to give them CFCs, this is clotting factor concentrates, until resolution of the bleeds. And if symptoms persist despite adequate factor replacement, if your patient had had a history of clotting factor concentrates before, then you want to think that probably they have developed antibodies against factor, what we call inhibitors, or you need to entertain another diagnosis, including fractures or even septic arthritis. Now, you want to make sure these patients are treated very well in terms of pain control, and we do not give these patients NSAIDs because they normally have antiplatelet effect, and therefore they worsen the bleeding. So unless you want to give them selective COX inhibitors, which would then be much better. So this patient should also be sent to physio, and normally physicians or rather doctors will send these patients to physio once they are ambulating. But remember, even in the early stage, things like splinting, giving them walking aids are things that can be given in physio, so you want to send them early. CNS bleeding is something that we think we must emphasize, and this occurs in patients because of probably head trauma, and they normally present with headaches, somnolence, or other sort of symptoms of raised intracranial pressure. Now, if a patient with hemophilia presents with sudden onset severe back pain, you should also entertain the possibility that they may be bleeding in the spinal cord. Now, it's important to understand that if you know your patient has hemophilia and they are presenting with symptoms of CNS bleeding, you want to give them factor replacement therapy first before you proceed to other investigation. And this is very important because sometimes patients have died in the corridors of hospitals trying to get into the radiology department, confirming whether it's really a CNS bleed. So you give them factor, replace it fast, then you go on to confirm what you think could be going on. And it is a life-threatening bleed because the patient can actually die. Now, imaging, as we've said, we still emphasize should be done after you have replaced your factor concentrates. And these are patients who are candidate for secondary prophylaxis, meaning that once you have managed that CNS bleeding, you want to put them on routine prophylaxis. That is, you do not wait for them to bleed. You want to give them factor therapy 2-3 times a week, depending. And actually, this therapy could be lifelong because once it's occurred once, it can actually occur again. Patients with throat and neck, so either because of local trauma, severe coughing, or local pathology, including tonsillitis, could have bleeding. And this is, again, very crucial because it could have cause airway obstruction, which is fatal to the patient. So this patient should be admitted first, given factor therapy, and then have evaluation of their airway by the ENT surgeon. And patients who've got tonsillitis who have hemophilia should also be given CFCs over and above antibiotics and tranexamic acid, because you know that once the tonsils are very friable and could easily bleed, then they could predispose this patient could predispose them to then having this throat and neck bleeding that could compromise their airway. GI bleeding is another life-threatening bleed, and your patient could present with hematemesis, hematochezia, or Melinas too. And your patient could actually present as if they have acute abdomen. So they may present with pain, distension, or even paralytic ileus. So this is a patient you also want to identify very quickly. You want to admit them and do factor replacement therapy as you begin to probably rule out other causes of that kind of acute abdomen presentation. Now, patients who've got liver disease over and above having hemophilia could prompt that could sort of hint to you that they have GI bleeding when they have hepatic encephalopathy. And this is because they're not able to break down protein, and as a matter and because of that, they're not able to break down toxins that come from protein metabolism, which will then affect their neuronal function. So these are patients who can present with hepatic encephalopathy and therefore just make you think, oh, probably this patient has a GI bleed. So we said we admit them, give them tranexamic acid, give them pain relief, and therefore once you have given them factor, you can begin to send them for endoscopy for evaluation of GI ulcers and aspects like that. If they have hepatic encephalopathy, usually lactulose will give them relief. And this is just to show you how you want to replace factor for life-threatening bleeds. And this is you raise your factor concentrate to 100%. And this is you continue with infusion for about 3 weeks. So in about the first 3 days, you give them 100%. 4 days, you drop it down to 80. And after that, you replace them at 50% for the next 2 days. And then again, these are patients who should be on long-term prophylaxis. Oral hemorrhage, again, is something that we encounter, especially with dental extraction. And usually we suggest that if you have a patient with hemophilia, the moment they start showing this deciduous teeth, you want to take them to your dentist, because you want them to have very good oral hygiene so that you don't have gingivitis and end up with this kind of bleeding. So normally for oral bleeds, we replace them, you give them CFCs, tranexamic acid, and direct pressure on the socket if you were to do a tooth extraction. And this is the other thing you can do. You can make sure you have sutures, depending on the bleed. You can use local hemostats. And again, just emphasizing the importance of tranexamic acid. Usually these patients, especially when they now have oral kind of pathologies, you want to advise them to be on soft diets, avoid vigorous brushing, and refrain from extreme sport or contact sport. And again, these are patients who you want to replace their factor levels anywhere between 20 to 40%, and you can raise it depending on how they respond to their initial replacement therapy. So this is just to show you how you calculate your dose. And remember, we said that for patients who've got hemophilia A, when you give them 1 international unit per kg, you've literally raised them by 2%. Now, if they have minor bleeding, and these are, maybe they have oral bleeds, for example, these are minor cuts, you want to replace them at 20%. But if this is 20 international units per kg, but if they have major bleeding, this is CNS bleeding, GI, you give them at 40 international units per kg. This is not percent, but the international units per kg. And this is what you give them if they have factor 9 deficiency as well. Now, I wanted to show you this table that would normally, and if you're able to share the slides, you would then have a look at this, but it was also you can find it in the guidelines, the WFH guidelines for the treatment of hemophilia. And this is just something to guide you. So if your patient, for example, who has hemophilia A, presented with CNS bleeding, for example, how do you manage them? So you want to replace your factor to between 80 to 100% initially. This is between the first 7 days. And then you give them a maintenance of about 50% going up to 3 weeks. And remember, we said this patient should also be on long-term prophylaxis. If you had surgery, again, if it was a major surgery, you want to replace them at 100%. This is before, this is pre-op. And then you want to give them post-op. You can be able to see how we are able to cascade down from the first day going all the way to the 2 weeks post-surgery. So this is just a table that you can have and can be very handy when these patients are presenting to you, just knowing that there's an initial dose you give them, and depending on the type of bleeding, how then you will maintain them over time. This is usually given, this table is when you do not have significant resource constraint in your region, but there's also a second table that I have here that is also allowed by the World Federation of Hemophilia for us to use if you have significant resource constraint, and you can be able to see that the factor replacement levels are coming down, but still they are effective. Now, as we wrap up, we'll just mention a few things about patients with inhibitors. And basically, these are alloantibodies that are produced by patients who've had previous CFC exposure, and they are neutralizing antibodies that render the patient refractory to treatment. And they should be suspected in the event of prolonged bleeding after infusion for patients who are previously responding to factor therapy. So you classify them either as high responding or low responding, depending. And this is just information that you can get from your lab. And basically what this slide is to emphasize is that patients with inhibitors are given bypassing agents. And these are agents that contain already activated factors that the patient can use without necessarily now having need for the CFCs, which generally they would not respond to. So one of them would be Faber that we give, that is activated prothrombin complex that has activated factor 9, activated factor 2, and also 10. And usually I've just highlighted the kind of formulation, the dosage that can be given to these patients. Another one that we can use is Novo-7, again, just another bypassing agent for patients who've got inhibitors. For patients who've got who are low responders, there is role for us boosting the amount of factor we give. So instead of replacing them at 100, you can go all the way to 200 and 300, trying to just submount the inhibitory effect of the antibody. So we'll wrap it up there and then hopefully fill up some of the things we have not covered in our Q&A, but just to give us this as our take-home message that it is a rare X-linked disorder that occurs and whose hallmark is bleeding, that males are more affected than females, but females can also have hemophilia. Presentation is based on phenotype and severity, and management of bleeds depends on the site, severity of hemophilia, and when CNS bleed is suspected, or rather when major bleeding is suspected, you want to give them factor therapy first or bypassing agent before you send them for investigation. And therefore, factor therapy is escalated or de-escalated depending on how the patient responds. So we'll leave it there and welcome the second presenter. Thank you.
Thank you very much, Dr. Mwakichako, for that rich and informative presentation. And I want to appreciate the presence of, more than 700 participants. So it seems that people are so much willing and wanting to know more, so curious to know about how hemophilia is managed. So I want to take this opportunity to welcome Sister Rosanne Angoche to continue with the presentation touching on girls and women. Welcome, Sister Rose. If you are ready, you may continue.
Okay, good evening. Can you see my screen?
Yes, it's visible.
Okay. Okay, as you've heard, I'm Rosanne Anguche. I'm going to tackle bleeding manifestations in women, in girls and women. For bleeding manifestations in girls and women will present in various forms. We find that there is heavy menstrual.
Sister Rose,
Yes.
If you don't mind, can you put the slideshow?
Slideshow.
I hope it doesn't interfere with your presentation, but you may put it on slideshow.
Is it okay?
Yes, it's perfect. Continue. Thank you.
Okay. Bleeding manifestation in girls and women present in various forms. That is in heavy menstrual bleed, that is menorrhagia. You find that there's soaking through pads and tampons, and you find that you find that these women will change pads and tampons within an hour, and there's clots. They present with clots that are bigger than grapes, and you find that also bleeding is more than 7 days. There's also bleeding between periods, so you find that there's spotting in between periods. After one cycle, you find that after one cycle, you find that the lady can have the spotting after a week or just weeks after the periods. There's also bleeding after menopause. Find that any vaginal bleeding after menopause is considered abnormal, and bleeding during intercourse also, this is a sign of other things or other condition other than the ones that we know. There's also bleeding during pregnancy. There's any vaginal bleeding during pregnancy needs immediate medical attention. So these women who have this bleeding manifestation find that they'll have this kind of presentations in various ways. There's also easy bruising. Find when having large bruises after small bruises, find that there are large bumps after an injury. Okay, bleeding manifestation also predisposes these women to be called women bleeders. And who are women bleeders? Women bleeders present with different kinds of bleeding, and we always ask them if they know the normals or if they know what is not normal. So you find that even when a lady is menstruating or spots a mens, you find that these young girls do not share about themselves, and they do not even want to find out about how the other one is faring on and how their menses are. So they don't know about the normal. They don't know what to get or what to expect. So you find that they're always confused, and they're wondering, is it the normal way of having my menses? Sometimes they prolong up to more than seven days, or they go for many weeks. So I find that they don't know which is normal, or they don't know what to expect during these menses. So why are we talking about the women bleeders? This is to educate and empower healthcare professionals, women and girls about congenital bleeding disorders that affect females. And this is to enable them to have a prompt access to treatment and accurate diagnosis. These women bleeders are they are predisposed to different categories of bleeding disorders. You find that, just as Makitaka was saying, you find that these girls who are born to hemophilia fathers tend to inherit the genetic trait, the hemophilia trait from their fathers. So I find that as they grow, they start, when they reach their menses, they start having very heavy menses. And when they go through maybe dental work, they bleed a lot. Or when they go through surgeries, you find that they lose a lot of blood. And when they go through the childbirth, you find that they lose a lot of blood. So the females who inherit the genetic trait of hemophilia, you find that they go through much bleeding. Then there is von Willebrand's disease. Many women present with von Willebrand's disease, and when it is running in a family, because it's a genetic condition, find that this affects both male and female equally. So what makes ladies to be concerned about von Willebrand's is because they bleed a lot. They have heavy menses. When they have nosebleeds, they bleed a lot. Or when they have bruises, they find that they lose a lot of blood during this time. So that's what makes ladies to be very concerned about the condition. But men may present with only nosebleeds or very few bruises as compared to women. So I find that there are different types of von Willebrand's condition. We have type 1, which is very mild, type 2, which is moderate, and type 3, which is very severe. So I find that women with the type 3 von Willebrand's condition are the ones that have severe bleeding tendencies. But as much as these women go through this condition, find that they have very many bleeding tendencies. Then we have the platelet disorders, that is qualitative and quantitative. Qualitative is structural and functional presentation of the platelets, and qualitative is numerical presentation of the platelets in the system. So I find that these ladies come up with conditions like Bernard-Solwak syndrome, ITP, and another one called Glanvill's thrombocythemia. I find that these women who have these types of platelet disorder bleed very oftenly, and find that most of the time they're undiagnosed, because we have very few patients in Kenya who are diagnosed having platelet conditions. Some of them are diagnosed out or in private facilities, but I find that our patients are low income, are in low income families. So I find that they can't actually go for diagnosis because it is very expensive. So they just go for platelet transfusion. Also have rare clotting factor deficiencies like fibrinogen, that is factor 1 deficiency, factor 2 deficiency, factor 5, factor 7, factor 9, and factor 10 sometimes, and factor 13. So they present differently with different kinds of factor deficiencies. So find these women coming up with different bleeding signs, symptoms, because they have different factor deficiencies. The cause is basically genetic, and sometimes you have some of them having acquired due to maybe medical condition they have, or maybe the drugs they are taking. So they end up having an acquired genetic condition that predisposes them to bleeding, and they are supposed to be handled separately for clarity and just to help the patient be able to be diagnosed in the right way and be managed in the right way. So bleeding symptoms in women, we have seen that there is heavy menstrual bleeds. And these heavy menstrual bleeds, these bleeds go for more than 7 days. There is flooding and gushing of blood that causes limited daily activities. Find that they overbleed, and you find that they can't do the activities normally like other normal ladies. Find that their quality of life also goes down, because you find that because of the heavy bleeds, they're not able to. Sometimes their social life is also affected, because they tend to stay longer in the house because of the heavy bleed. They're not sure if they'll go out there and not end up staining themselves. There's also passing clothes that are bigger than a quarter, that is bigger than a grape, and find that these clothes predispose them to just staying away from other people, or toiling away, so that because they end up using facilities and they end up maybe missing the facility that is around them. So they tend to toil in the house and find that their daily activities are affected. There's also changing of tampons on and off, maybe hourly or within maybe less than an hour, that on heavy days, and you find that it makes them very uncomfortable, and they might not actually open up to say what is happening with them. There's also being low in iron and have anemia. You find that this overbleeding causes these ladies to almost have low HBs. So most of the time they're either taking foods to replace, or they're on treatment to replace to boost up their HBs. They also have bleeding symptoms because of their family. They have a bleeding family condition, and you find that maybe you could find in a hemophilia family, their brothers could be having hemophilia. They could be having a father who has hemophilia. They could be having an uncle who has hemophilia, or their mother could be a carrier. So they actually inherit this from their family members, and they find that this family is actually affected because of the bleeding tenderness. There is heavy bleeding from dental surgery, that is dental works, other surgeries that they go through, and they end up also bleeding during childbirth. So these are the mothers who end up having BPHs, and they die in our labor wards and undiagnosed because they couldn't get to diagnosis early. There's frequent nosebleed that last more than 10 minutes, and sometimes it is so heavy, sometimes soaks up the clothes, soaks up the towels and the laces that they're using, and it takes a longer time to clot. So it gives them a lot of concern about themselves, and some of them think they're actually abnormal. And if in the setting in our country, in our settings, because they come from low income backgrounds, find that some of them think they're actually bewitched. So they actually tend to coil up and close up themselves from the outside. There's also bleeding from cuts that last longer than 5 minutes. So hemophilia patients, how they take longer to clot. So they find that the clotting period takes longer, and find that they wait for this clotting time to come. There's also easy bruising. Even with a smaller scratch, you find that it builds up to form a bigger bump. Lab diagnosis begins with bleeding history assessment. You need to actually do a good history, like a family tree. That one will find out what is happening with the patient, and they tell you, I come from a hemophilia background. They tell you, I have a hemophilia brother. My father bleeds, or my mother has this presentation. So they tell you what they know. So it is good to have a good history assessment. And then also there is a bleeding assessment tool that you give them to fill. And as you tick, you get the patient through the tool, to find that the patients will score highly, actually tending to the higher mark of bleeding condition. So this is how you get your patients with the bleeding tool. There's also bleeding assessment tool, self-bleeding assessment tool that is dubbed desktop periods. And you find that these ladies who have these heavy menses, when they go through this, you find that they score very highly, pointing them to a given bleeding disorder. There's also molecular genetic testing that we don't do here in Kenya, but those who are able also can be done outside, but it's actually very expensive. Most patients don't go for genetic testing. Just find out which kind of mutation happened to my lineage that I have this. So you find that most of them will have, when in other countries which do the genetic testing, you find that a family knows which kind of mutation happened for them to have a bleeding disorder. But for us, we have not been able to do genetic testing for our patients. There's also coagulation testing, that is baseline APTT, PT, and mixing tests if the patient the characteristic of the patient is leading towards hemophilia, and then the specific factor assays for the patients maybe who have a von Willebrand's condition. You can do factor assays to just tell you if the von Willebrand factor is low in the system, or you find that if it's low, you find that also factor 8 will be low. So this one will give you something to tell. This one will give you a mind that this patient will be having von Willebrand's condition. There's platelet function test that is done for the patients who have platelet disorders, and we also do platelet aggregation that we have not done for most of our patients. And we have not actually singled out these patients because we are not able to test this in our labs. There's von Willebrand specific type identification test that we do, the antigen and the activity testing. The antigen will actually tell you which kind of von Willebrand this is, and the activity will tell you the amount of von Willebrand factor that is circulating in the system. Then treatment or management, you find that if we have a symptomatic hemophilia carriers, these are hemophilia ladies, or these are women who have a genetic dispensation of hemophilia, and they present with bleeding tendencies. So these women, find that for them to live normally, we find that we do a multidisciplinary management, and most of them are put on oral contraceptive. Sometimes when it is too much on the extreme, and they're going through maybe procedures like surgeries. Some of them are going maybe to get to do childbirth. They also are given factor infusions apart from the oral contraceptive that they are given. They are given progesterone only pills, because progesterone only pills will reduce or stop bleeding for hemophilia ladies, and because it inhibits the growth of the lining of the womb or the myometrium before your period starts. So most of them are actually put on progesterone only pills, and sometimes factor infusion, but we actually don't give factor because of their factor dispensation. They're not patients; they're just carriers. And we have also intrauterine devices like coil, so that they actually do not overbleed. Then we also depend on tranexamic and aminocaproic acid, but most of the time we do tranexamic for them, and we keep on changing the dosages just to take care of them. If they're overbleeding and they can't do anything, we have to actually boost up the dosage. If they are normal, the bleeding is coming to normal because of the oral contraceptive, find that they're maintained on the normal tranexamic acid dosages. We have von Willebrand disease. Von Willebrand disease is managed by desmopressin. Desmopressin is a recombinant factor TFC. You find that has factor 8 concentrate that is very high in very high dosages, and you find that this one is given to this patient because von Willebrand factor encapsulates factor 8. So if you have low factor 8, you also find that the patient will have low von Willebrand. And if you have a defective von Willebrand, you find that the patient will have low factor, also defective factor 8. So a patient is given DDVP just to make sure that they are boosting up factor 8, just to make sure that von Willebrand factor is maintained in the normal amount. There's also recombinant von Willebrand factor infusion that we have in our facilities, and it's given to our patients, and also blood products that is cryoprecipitate. Then you have estrogen only pill that is given to these patients apart from the factor infusion, and a progesterone only pill will also stimulate the endothelium. You find that factor 8 and von Willebrand factor are affected in the endothelium and the endothelial cells. So I find that actually this estrogen only pill will increase production of von Willebrand by stimulating the endothelium cells to help them produce more von Willebrand factor. Then you find that they're also dependent on an antifibrinolytic that is tranexamic. Then you have platelet disorders, that is Benalsolua and Glanzmann's thrombocythemia that we mentioned, and find that the management of this of platelets is just platelet transfusion in our facilities, and that's what majorly we do. We have recombinant factor 7, but you find that it is very low in supply because our donors give us very little, basically for surgeries and maybe major activities that we think that we want to do. Like if a patient goes through maybe a surgery, or a patient has gone through factor infusion and has developed inhibitors, then we'll have to switch to Novo 7. So we are given very little Novo 7, and therefore we just keep them for such conditions. Sometimes we have we end up doing hysterectomy for these patients at a very young age, and we have had so many women at maybe at 35, at 38 actually signing for hysterectomy. Yeah, we mentioned about Glanzmann thrombocythemia, about that is a platelet disorder, and we find that platelet transfusion is given in case the patient comes to the facility, and then there is a tranexamic that's also given, and recombinant factor 7 in case of surgeries or other defective other factor deficiencies. Then we have rare factor deficiencies that patients end up having, that is factor 7, factor 2, factor 5, and factor 11 and factor 13. These patients are managed according to their factor deficiencies, and they are given, some of these patients are given either progesterone only pill or estrogen only pill, because they present in different ways. So just to note that multidisciplinary approach is extremely recommended in the management of women and girls with bleeding disorders. And this also need to involve a hematologist, a gyna, orthopedic surgeons. Sometimes they end up having deformities, so you need also orthopedic surgeons. You have anesthetists that need to come in discussion. They have dentists, nurses, genetic counselors, and coagulation, laboratory help in coagulation. So patients are actually managed in a multidisciplinary way, just as we saw in hemophilia, to just make sure that we are on the right track in our management. Yeah, thank you. That is the end of my presentation. Thank you.
Thank you very much, Anguche, and for that informative presentation touching on girls and women. Now, I would want to go to the next section, which is the question and answer. And I see quite a number of questions have been asked, and I hope that we are able to answer some of your questions, though we may not answer all of them verbally, but we can also type, and I hope that we are going to clear probably your queries. Good. So there are questions touching on management of hemophilia, and also there is another question touching on our systems in Kenya, especially which centers handle hemophilia patients. So I'll allow Dr. Mwakichako to touch on that. So let me welcome you, Dr. Mwakichako, so that you can at least tell us the centers, how many centers in Kenya. And I can see someone asking whether there is a station in Mombasa, another one asking whether in West Pokot. So maybe you can try and inform if maybe there are centers near them from where they can benefit. And then maybe we go to the management of hemophilia.
Right. Thank you very much for that question. Yes, for people who are asking about Mombasa, CPGH has a treatment center, actually almost becoming a comprehensive center for patients with hemophilia. So they are able to go there. Kwale does have a center, Kilifi as well. We have one in Voi. So that covers then the coastal belt. And for West Pokot, I'm not sure. I'll have to ask Anguche, but I know MTRH can be able to support that for those patients. Anguche, might you know about West Pokot?
Okay. Okay, West Pokot, we do not have a facility in West Pokot, but we have a facility just close in, where can I say? Okay, our facility is just close to West Pokot, and I don't know what but we have a facility close by because of the distance. That was the last one to be opened recently. I am here to check on the term that was opened.
Oh, I think you're talking about Kapenguria.
Yes, Kapenguria.
Yeah.
That one was the last facility that was opened, I think, last month.
Yes, thank you. Thank you, Dr. Mwakichako, and also Sister Anguche. Then there is one asking about prophylaxis for hemophilia. How long does it take and when can it be stopped? I throw it to Dr. Mwakichako.
Right. So I'll answer it by saying that prophylaxis is actually the standard of care for patients who have hemophilia. And it can actually be lifelong, depending on the ages that you use, especially like for patients who are on emicizumab, getting monthly injections, weekly or by monthly, depending. So being the standard of care, it can actually be given lifelong. The only challenge would be sometimes if you're giving CF clotting factor concentrates, and then you'll have issues to do with stockouts or shortages. But in case you have shortages and you have patients who have CNS bleeding, and you may not be able to sustain long-term prophylaxis, at least the first 3 to 6 months, going up to a year, you need to ensure the patient is on prophylaxis. But at least it should be known that prophylaxis is a standard of care for patients with hemophilia, and where available, all your patients should be on prophylaxis.
Yes, thank you. Now, I wanted to ask maybe a quick question. What is the average age of diagnosis in the patients, probably statistically in Kenya? And what is the life expectancy? Probably you can give us a quick answer.
Is that for me or for Sister Ngoche?
Yes, for you.
Right. So I may not be able to have the statistics on the average age at diagnosis, but what I would say is that now, with the knowledge of hemophilia in the country and the kind of support that KH is providing, we are beginning to see diagnosis as early as I think I once had a patient who was about 6 months at presentation. So it will depend on whether the knowledge is available at the particular place where the patient is, as well as the severity. So depending on whether they are severe type, then they're likely to be diagnosed earlier. So probably we'll need to check with our records so that I can share an accurate figure. But I would say, I think I know somebody who is in their 60s right now who's got hemophilia. So because of good support with CFCs, we've seen quite a number of elderly patients now beginning to show up in our clinics. Yeah, but I need to confirm the actual figures.
Okay, maybe to just add on that is that life expectancy for hemophilia patients, just like any other normal human being. It's only that they have low clotting components. But because of the availability of the clotting components that are just close to the patients, we find that most of our patients are living up to actually actualizing their ages. We have a 73-year-old, we have a 68 right now, we have a 64, a 63, a 61, and several patients in 50s, but you find that these older patients have deformities because they were not exposed to enough factor, just like the ones who are now growing up right now and the young adults. They were not exposed to enough factor. So I find that they have 1 or 2 deformities, but they actualize their ages, unless they go through maybe risky eventualities, like maybe road traffic accidents, or maybe something that will cause death other than hemophilia. Yeah.
Thank you. Maybe on you, Sister Ngoche, you can be able to tell us, but I know also Dr. Mwakichako has a great contribution to it. There's an attendee who is asking, who works in Nairobi Blood Transfusion Center, and is asking about, they prepare the cryoprecipitates, but they end up expiring there. Do you think maybe it's about the healthcare workers who really don't have much awareness about how to manage, or I don't know what your take would be?
I think right now, just as Mwakichako had mentioned, we find that our patients are exposed to recombinant factor. So most of them are actually going for the recombinant that is now is widely spread in different facilities in the country. We have 25 facilities, and we find that most of our patients are able to reach the facilities to get the recombinant. And unlike previously, where there was no recombinant or was low in supply, is when we would actually struggle to look for cryoprecipitate or FFP. So right now, if there is no actually factor in the country, we get factor from at least neighboring countries like Tanzania, and we get support. But we do not end up going to lower supplies, because the donors have been very gracious and their supply has been very steady.
Okay,
So
thank you very much. Again, let me ask, this has been asked regards to girls and women. That is the ANC for probably to detect early the hemophilia. I don't know whether there is much you can actually respond in that, so you can help us understand more prophylaxis and maybe towards delivery, if maybe there are measures that are already in place, especially where you work.
Okay, for us, when we are having a hemophilia, a lady from a hemophilia setup or of a hemophilia family, we actually really take care of our patient, of our lady patients, because what we know, we already have known where they're coming from. They come from a hemophilia background. So what we do, we do not do. We do not do the screenings per se, because we know this is a patient who can overbleed or who can bleed heavily during the childbirth. So what we do, we only make people aware who are handling these patients, especially the nurse whom this patient is going to go through their hands. We just make them aware, and we support them during this time with factor, so that at least during this time when they are overbleeding, we give factor, and we give high dosages of tranexamic to just make sure that the patient is safe.
Thank you for that. Then probably I want to ask this that has been asked, and Dr. Mokichako is well placed to tell us. There's an attendee who is asking whether there's an association for these patients. And I know when introducing you, there's something I mentioned in regards that. So let me give you that space so that you can answer the question.
Right. So I'll answer the question, but allow me to just add something on what Roseanne talked about in terms of management of patients who've got probably hemophilia in the obstetrics background. So we know very well that usually factor levels will go high when they are pregnant. So this is both factor 8 and von Willebrand's factor. And even in their third trimester, when their factor levels are about 50%, usually these patients are predisposed to bleeding. So what you can do in your ANCs is that, and I know that there is already some work that the Ministry of Health is trying to do in terms of adding hemophilia and bleeding in our ANC booklets. So for us who are handling these mothers, you can quickly do screening questions like, are your menses heavy? Do you have a previous history of PPH in your other pregnancies? Do you have hemophilia patients in your family? And if you've got some of these things coming up as yes, then you want to screen these patients. And as Anguche rightfully said, these are patients who should be put on factor when they go for delivery, but you also want to add that vacuum and forceps delivery is not recommended for this particular patient, especially carrier mothers or hemophilia patients. So if you know very well that you will probably need forceps or vacuum, you might even be safer with a cesarean section if then you have the background of factor therapy given to these patients. And again, once these patients are delivered, and especially male patients, you want to send them for transcranial Doppler for transcranial ultrasound, because you want to look out for the risk of CNS bleeding for some of these patients. And then lastly, to your question on association, yes, there's a very robust association that we have, that is Kenya Heamophilia Association. That is the umbrella body that takes care of patients with hemophilia, and it has got a medical advisory committee where Anguche and myself are, and also has a very active patient support group and advocacy group. So it has aspects to do with supporting in diagnosis, treatment, and advocacy for these patients. So for any particular patient that you find, you can reach out to the KNH clinic. They are very well able to connect you to KHA, because we'd want all these patients to receive care wherever they are in the country. Yes. And they've got very many social media pages. I know they're on Instagram, they're also on Facebook. So just go on and check for Kenya Haemophilia Association, and I'm sure you'll get a lot of help there. Yeah.
Yeah, I also just want to mention that the association is actually a hybrid association where we have the patients in the group, we have the parents, and also it is actually like a triangle. So whatever the medical fraternity does, it actually has to incorporate the patients and the parents. So it is a hybrid, and it is very robust, just as Mokichako is saying, and actually fronts the needs and the needs of the patients, the parents, and even the clinicians who work in this in their facilities. Yeah.
Thank you for those responses. Maybe now as we wrap up, are there any closing remarks, Dr. Mokichako, Sister Anguche, and then we can now come to a close.
Right. For me, I'd like to just appreciate all of us for joining in, and to just say that you would be surprised what the knowledge of hemophilia can do for your facility. Because the most important thing for you to do is to just entertain the diagnosis of hemophilia for a patient who's presenting with these symptoms, and it can literally change their lives, because then you put them on the trajectory for correct treatment. And also to say that there's a lot of linkages that we have within the clinical, the different clinics that we have with hemophilia patients. And if you have, if you're close to KNH, you can always reach out to the KNH clinic, which is comprehensive, as well as NTRH for the kind of support that you will need. And right now, Factor is available for these patients. And therefore, it is unfair for us to now have patients who are born in this age and time presenting with disability in the future, while correct diagnosis and care could have been made possible for them. So I think I'll leave that as my closing remarks.
For me, what I would want to say is, hemophilia and other bleeding disorders is actually a marginalized topic, and people think there are no patients. We have very many patients that present we have different presentations. So if you meet a patient, please let the patient get care, because we have very many facilities. We have open 25 facilities around us, and even if it is a private facility, find that our drugs, that is Factor is only disbursed in the public facilities. But in case you are anywhere and you meet this patient, please call out for help. Don't just leave the patient to go away. Just call KNH, call MTRH, call facilities around you, especially the public facilities, and you'll be helped. To find that you'll be surprised that you could be struggling to manage a patient, and they just Factor just close to you. So make sure that you actually front the needs of this patient, help these patients get care and also get diagnosis, because they're now being diagnosed anywhere. And that now most of our facilities, even the public facilities that people think have no machines, actually the KHA is helping donate the machines to these facilities that are very far, like Lodwar, Kakuma, and find that patients are being helped wherever they are. So if you have any patient, do not hesitate to come up, do not hesitate to find out, do not hesitate to just call out for help, so that you can help a patient get care and get good management. Otherwise, I want to stop there. Thank you for listening, and just thank you for attending this presentation.
Thank you very much. That was very rich, and thank you for sparing your time to share with us on your expertise, so that we can be able to improve on patient care. Now, as I close, just two reminders. Number one is tomorrow's session is a continuation of this one, and we are going to focus on other multidisciplinary approaches to hemophilia patients. So today we've talked about bleeding in women, and also we've talked about management. Tomorrow we'll touch on lab diagnosis. Then you're going to look at physiotherapy management and the nursing care, so that we can be able to see how the wholesome approach that we give towards patients suffering from hemophilia. And then lastly, just to invite you at Kenyatta National Hospital on the 16th of April, it will be on Wednesday. And we are going to commemorate the World Hemophilia Day that at a local level. And we are going to focus at least on 3 things. Number 1, patients are going to share their experiences. So it's just good you come and you hear what they go through and probably how best we've been able to help them manage their condition. Then number 2, we are going to do screening. Then lastly, but not least, we are going to touch on family tree tracing. So just come and have that day with us. So thank you very much. Have a blessed evening. And I look forward to meeting you next week at Kenyatta National Hospital.
Thank you.
Thank you.